Welcome, and thank you for joining me for this new series on the physiological foundations of critical care. Before we explore specific diseases or interventions, it is essential to remind ourselves why physiology sits at the heart of every decision we make in the intensive care unit. In critical illness, normal homeostasis is disrupted, sometimes abruptly and violently. Organs that usually work in harmony begin to compete for perfusion and oxygen, and the body's compensatory mechanisms quickly become overwhelmed. At that point, our role is to understand exactly what is failing, why it is failing, and how we can support or replace the body's own systems without causing further harm. Throughout this module, we will revisit the core concepts that guide safe, structured thinking in critical care, oxygen delivery, perfusion, cellular metabolism, and the dynamic relationship between them. These fundamentals shape how we interpret shock, how we assess a patient's trajectory, and how we choose our therapies, from fluids and vasopressors to ventilation strategies. This opening section sets the stage. Think of it as recalibrating your internal compass. Even experienced clinicians benefit from grounding themselves in the basic principles before diving into the complexity of modern ICU practice. So, let us begin by reconnecting with the physiological logic that underpins every life-saving action in critical care. Before we look at specific organ systems, it's important to appreciate just how remarkable the healthy body is at maintaining balance. Every moment, it adjusts blood flow, ventilation, metabolism, and fluid distribution with a level of precision that is easy to take for granted. When critical illness strikes, this delicate coordination begins to unravel. Mechanisms that normally compensate smoothly and silently become strained and eventually overwhelmed. Systems that usually support one another start to pull in different directions, each fighting to preserve its own survival. The signs we observe at the bedside, the rising lactate, the dropping blood pressure, the altered mental state, are not isolated findings. They are the outward expression of the body losing its ability to regulate itself. Our role in the ICU is to recognize this loss of homeostasis early and to intervene in a way that restores stability without adding harm. To do that well, we must understand the physiological foundations that normally keep a patient alive and functioning. So, in this section, we'll begin unraveling how and why homeostasis fails, and what that means for our clinical decisions in the critical care environment. Oxygen delivery is one of the most fundamental ideas in critical care. It represents the total amount of oxygen transported to the tissues every minute, and it determines whether cells can maintain normal aerobic metabolism. The equation is simple. Do2 equals cardiac output multiplied by the arterial oxygen content. But the implications are profound. A change in cardiac output, hemoglobin, saturation, or oxygen tension can shift the balance from stable physiology to cellular hypoxia remarkably quickly. In critical illness, one or more components of this equation almost always fails. The heart may not pump effectively, the circulating blood volume may fall, the hemoglobin may drop, or the lungs may struggle to oxygenate the blood. Our job is to identify which part has collapsed and how urgently it needs to be corrected. A key point to remember is that hemoglobin contributes far more to oxygen content than dissolved oxygen. This is why increasing friction of oxygen sometimes produces only a small improvement, whereas restoring hemoglobin or cardiac output can completely change a patient's trajectory. Understanding oxygen delivery is not an academic exercise. It is the basis of how we interpret shock while lactate rises and how we choose between fluids, blood, oxygen therapy, and vasoactive drugs. This equation sits at the heart of every resuscitation decision we make. Cardiac output is, quite simply, the volume of blood the heart can deliver every minute. It is the engine that drives oxygen and nutrients to every organ. When this engine falters, even slightly, the consequences are felt immediately at the cellular level. cardiac output itself depends on four key elements: heart rate, contractility, preload, and afterload. Any disturbance in these, whether from fluid loss, heart failure, sepsis, or obstruction, can undermine perfusion long before the blood pressure visibly falls. Perfusion is not just about achieving a particular blood pressure. It is about ensuring there is enough flow reaching the tissues to meet their metabolic needs. A patient may have a normal or even elevated MAP, yet still suffer from inadequate organ perfusion because the cardiac output is insufficient or because microcirculation has failed to distribute that flow effectively. This is why early recognition of circulatory failure matters so much. Changes in mental status, worsening skin perfusion, a rising lactate, or a fall in urine output often appear before any dramatic fall in blood pressure. So as we move further into the physiology of critical illness, keep this in mind. Cardiac output is the first and most sensitive marker of how well the body is being perfused, and almost every resuscitation decision we make, fluids, vasopressors, inotropes, ultimately reflects our attempt to restore or optimize that flow. Once oxygen has been delivered to the tissues, the next question is whether the cells can actually use it. Under normal circumstances, mitochondria extract oxygen efficiently and convert it into energy for every physiological process, from maintaining consciousness to sustaining normal ventilatory effort. In critical illness, this finely tuned system becomes vulnerable. Fever, shivering, inflammation, and the hormonal surge of the stress response all increase metabolic demand, pushing oxygen consumption higher than usual. At the same time, the mitochondria themselves may become impaired, particularly in sepsis. So, even when oxygen delivery appears adequate, the tissues may struggle to extract and utilize it. This mismatch between delivery and utilization is one of the reasons why lactate rises, even when the blood pressure and oxygen saturation seem acceptable. Understanding this concept helps us interpret abnormal lactate levels more intelligently and reminds us that treating shock is not simply about raising the blood pressure, it is about restoring meaningful oxygen use at the cellular level. Now let us take the next step and look at what happens when the cell can no longer use oxygen effectively. In healthy tissue, glucose is converted to pyruvate, and pyruvate enters the mitochondria, where it is processed efficiently using oxygen. This pathway produces far more energy than any alternative, and it keeps lactate levels low. But when oxygen delivery falls behind metabolic demand, a state we call dysoxia, the mitochondria begin to fail. The cell has no choice but to switch to anaerobic metabolism. At that moment, pyruvate is diverted away from the mitochondria and converted into lactate instead. This rise in lactate is not the problem in itself. It is a warning sign, a signal that oxygen utilization is no longer adequate to sustain normal metabolism. In critical illness, this shift can happen for several reasons: poor perfusion, severe sepsis, mitochondrial dysfunction, or a mismatch between oxygen delivery and oxygen consumption. Understanding this transition is essential because lactate is not simply a number to memorize. It reflects the struggle occurring inside every cell when oxygen becomes a scarce resource. Now that we have explored how oxygen delivery and oxygen utilization interact, let us introduce the concept that connects them: the oxygen extraction ratio. This ratio tells us how much of the delivered oxygen the tissues are actually removing from the blood. It provides an immediate window into the balance between supply and demand at the cellular level. Under normal conditions, the body extracts only about a quarter of the oxygen that arrives in the capillaries. This leaves a reserve for times of stress, such as exercise, fever, or early critical illness. When oxygen delivery begins to fall, the tissues compensate by extracting more. As extraction increases, the venous oxygen saturation falls. This change is extremely valuable to us because it allows us to detect impaired perfusion long before lactate begins to rise. However, Once oxygen delivery drops below a critical threshold, extraction can no longer increase. At that point, the tissues are forced into anaerobic metabolism, and we begin to see the consequences: rising lactate, cellular distress, and the onset of organ dysfunction. Understanding this ratio helps us interpret venous oxygen measurements, guides our resuscitation strategy, and sharpens our ability to recognize impending shock before it becomes irreversible. Now that we have explored the broad principles of oxygen transport, let us pause for a moment and focus on the quiet workhorse that makes most of it possible: hemoglobin. In critical illness, hemoglobin is not simply a laboratory value. It is one of the core determinants of whether tissues receive the oxygen they need to function or fail. Nearly all the oxygen carried in the bloodstream is bound to hemoglobin. Only a very small fraction travels dissolved in plasma. This means that even modest drops in hemoglobin concentration can significantly limit the amount of oxygen available for delivery, particularly in patients whose cardiac output and saturation cannot increase further. The affinity of hemoglobin for oxygen is also crucial. When the dissociation curve shifts to the left, unloading becomes difficult, and tissues may starve despite a normal oxygen saturation. When it shifts to the right, unloading improves, but sometimes at the cost of reduced loading in the lungs. In the intensive care unit, we constantly balance these forces. We look at hemoglobin not in isolation, but in the context of cardiac output, oxygen saturation, metabolic demand, and the patient's overall trajectory. This is why transfusion decisions must be thoughtful, personalized, and grounded in physiology rather than habit. At its heart, hemoglobin is a bridge between the lungs and the tissues. Understanding how that bridge behaves under stress helps us decide when to support it, when to replace it, and when the problem lies elsewhere. So, as we move forward, keep this principle in mind. Oxygen delivery is a chain, and hemoglobin is one of its most critical links. Now that we have explored what oxygen delivery truly represents, let us take a moment to walk through how each component behaves when a patient becomes critically unwell. Oxygen delivery depends on the heart's ability to pump blood forward and on the blood's capacity to carry oxygen. When either of these two pillars weakens, the entire system becomes vulnerable. Let us start with cardiac output. Imagine it as the engine that powers tissue perfusion. When the heart rate rises due to stress or shock, the body may initially compensate, but this cannot be maintained indefinitely. Excessively rapid heart rates shorten the filling time of the heart and eventually reduce the amount of blood ejected with each beat. Then we look at stroke volume. This is shaped by three forces: how much blood returns to the heart, how well the heart contracts, and the resistance it must overcome to eject blood. Any disturbance in these factors can make the heart's effort less effective. Finally, we consider the hemoglobin concentration. Even if the heart is performing well, oxygen cannot be delivered without sufficient hemoglobin to carry it. When hemoglobin levels fall, tissues are forced into a state of oxygen debt, and the consequences appear rapidly: confusion, rising lactate, and organ dysfunction. This formula is not just a mathematical expression, it is a living framework that helps us understand what is failing, why it is failing, and which intervention will genuinely make a difference. By grounding ourselves in these principles, we ensure that our decisions in the intensive care unit are deliberate, logical, and aligned with the physiology we are trying to protect. Let us now bring all of the elements of oxygen delivery together and look at how the lungs, the heart, and the blood each play a distinct role. Oxygen delivery begins in the lungs. Fresh oxygen enters the alveoli, crosses into the bloodstream, and binds to hemoglobin. This step is essential because the dissolved oxygen in plasma contributes very little to the body's total oxygen content. The majority of oxygen must travel attached to hemoglobin. Once oxygen has been loaded onto hemoglobin, the heart takes over. The strength and speed of each contraction determine how much oxygenated blood reaches the tissues every minute. If the heart is beating too quickly, too slowly, or too weakly, the overall delivery of oxygen begins to fall. As blood travels through the circulation, hemoglobin releases oxygen to the tissues. This release depends on local conditions such as temperature, acidity, and carbon dioxide levels. When the metabolic demand rises, for example, in fever or sepsis, the tissues ask for more oxygen, and hemoglobin responds by unloading more rapidly. The formula shown here reminds us that oxygen delivery is not controlled by a single organ. It is the combined output of lung function, hemoglobin concentration, oxygen saturation, and cardiac performance. If one of these factors fails, the entire system feels the impact. Understanding this interconnected pathway allows us to choose the right intervention at the right moment. Sometimes the patient needs improved ventilation, sometimes a blood transfusion, and sometimes support for the heart itself. Our role is to decide which link in the chain is weakest and restore balance as quickly and safely as possible. When we speak about oxygen delivery in critical care, we often focus on cardiac output or the efficiency of ventilation. However, hemoglobin itself determines how much oxygen the blood is capable of carrying. Each molecule of hemoglobin contains 4 iron-binding sites. These sites hold oxygen with a strength that allows safe transport through the bloodstream, while still permitting oxygen release at the tissues. The amount of oxygen carried by hemoglobin is not fixed. It depends on several dynamic factors: the concentration of hemoglobin in the blood, the percentage of those binding sites that are occupied by oxygen, and the shape of the hemoglobin-oxygen dissociation curve, which shifts according to temperature, carbon dioxide, and acidity. In critical illness, these relationships become even more important. A patient with healthy lungs but a severely low hemoglobin level may still experience tissue hypoxia. Conversely, a patient with an adequate hemoglobin concentration but impaired oxygen saturation will also suffer reduced oxygen delivery. Understanding these interactions allows us to make better decisions about transfusion, oxygen therapy, ventilator settings, and circulatory support. It also helps us anticipate when compensatory mechanisms are becoming exhausted, well before organ failure occurs. So, as we move forward, remember this simple truth. Hemoglobin is not just a number on the laboratory chart. It is the main vehicle that carries oxygen to every cell that depends on it. Let us now shift our attention to 2 measurements that many clinicians encounter every day, yet often misunderstand. These are the partial pressure of oxygen in arterial blood and the peripheral saturation of oxygen. Although they appear closely linked, they tell us different stories about the patient. The partial pressure of oxygen reflects the amount of dissolved oxygen in the blood, a relatively small portion of the total oxygen content. In contrast, the saturation of oxygen describes how many of the hemoglobin molecules are carrying oxygen. This distinction becomes especially important in critical illness. A patient with severe anemia may show a normal saturation level, yet deliver far too little oxygen to the tissues because the hemoglobin reservoir itself is depleted. On the other hand, a patient with lung injury may show a reduced partial pressure of oxygen, even when hemoglobin concentration is perfectly adequate. Understanding the relationship between these 2 measurements, and more importantly their limitations, allows us to interpret the patient's true oxygenation status rather than relying solely on the monitor. So, as we move forward, keep one principle in mind: no single number can describe oxygenation fully. It is the context, the physiology, and the patient's overall trajectory that guide our decisions in the intensive care unit. The next principle we need to understand is the oxygen-hemoglobin dissociation curve. This curve describes how readily hemoglobin binds to oxygen in the lungs and how readily it releases that oxygen to the tissues. It is not a straight line. Instead, it has a distinctive S shape, and this shape explains many of the clinical patterns we see in the intensive care unit. In the upper part of the curve, small changes in the partial pressure of oxygen do not have a large effect on the saturation level. This is one of the reasons why the body can maintain a stable oxygen saturation even as lung function begins to deteriorate. However, once the curve reaches its steep portion, the situation changes dramatically. A small reduction in the partial pressure of oxygen can lead to a rapid fall in oxygen saturation. This is the dangerous zone where tissues begin to experience oxygen shortage very quickly. The position of the curve can shift to the left or to the right depending on the patient's physiology. A shift to the left means hemoglobin holds on to oxygen more tightly. This may help loading in the lungs, but it makes release to the tissues more difficult. A shift to the right means hemoglobin releases oxygen more easily, which can be helpful during fever, sepsis, or increased metabolic demand. Understanding where your patient sits on this curve is essential. It tells you whether the problem is oxygen loading in the lungs, oxygen carrying in the blood, or oxygen release at the tissues. In the end, the dissociation curve is not just a graph. It is a map of how oxygen moves through the body. And it helps us decide when to adjust ventilation, when to transfuse, and when to address the patient's metabolic state. Now that we have explored the shape of the oxygen hemoglobin dissociation curve, let us examine the major factors that shift the curve to the right or to the left. These shifts are not abstract ideas. They represent real physiological conditions that alter how tightly hemoglobin binds to oxygen and how easily it releases that oxygen to the tissues. A shift to the right means hemoglobin releases oxygen more readily. This is seen in conditions with increased temperature, elevated carbon dioxide levels, reduced pH, or raised concentrations of 2,3-dephosphoglycerate. In simple terms, the tissues are demanding more oxygen, and hemoglobin responds by letting go more easily. A shift to the left means hemoglobin holds on to oxygen more tightly. This occurs in situations such as hypothermia, reduced carbon dioxide levels, increased pH, or reduced 2,3-dephosphoglycerate. The lungs may load oxygen effectively, but delivery to the tissues becomes more difficult. For the clinician in the critical care environment, recognizing these shifts is essential. They help explain why a patient with sepsis, fever, or metabolic acidosis may extract oxygen better, while a patient who is cold, alkalotic, or receiving stored blood may struggle with tissue oxygenation despite a seemingly reassuring oxygen saturation. Understanding these influences allows us to anticipate changes in oxygen delivery, to interpret arterial blood gas results with more precision, and to intervene in a way that restores balance rather than disturbs it.